Welcome back to the deep dive. Today we are stepping into the messy, urgent, and often pretty surprising world of traumatic dental injuries, or TDIs.
And when you say surprising, the prevalence is just, it's shocking.
It really is. Think about this. 25% of all school children and a staggering 33% of adults, that's 1 in 3, have had some kind of trauma to their permanent teeth.
That statistic is impossible to ignore. It really shows why this isn't some niche topic for specialists. I mean, it's a public health issue.
Totally. And managing a TDI, especially in an emergency, can feel, well, overwhelming. The rules are so specific, and the consequences can be permanent.
Exactly.
So our mission today is to cut through that complexity. We want to give you the distilled, actionable knowledge you need. We've gone through the latest clinical guidelines, especially from the IADT and some core clinical studies.
And we're going to focus on 3 absolute critical areas.
Mhm.
First, understanding the subtle differences in injury types that really define a tooth survival.
Okay.
Then mastering the immediate steps for a knocked out tooth, that famous 60-minute clock.
Right.
And finally, what the absolute gold standard for prevention looks like, which actually comes down to some very specific material science.
Okay, let's unpack this, starting with just the landscape of dental trauma. When these injuries happen, it's most often the maxillary central incisor, the front 2 teeth that take the hit, right?
It makes perfect sense visually. They're the most exposed,
And it's usually just a simple crown fracture.
usually. And, contrary to what people might think, most of these aren't from extreme sports. The vast majority are just accidents at home or at school.
Really?
Yeah. Clinically, the risk factors we look for are things like an abnormal overbite or incomplete lip closure. And then, of course, the obvious one, not wearing a mouth guard.
Before we get into the injuries themselves, let's do a quick refresher on the anatomy, because a tooth's ability to heal really depends on its internal plumbing.
Right. So you have the porous dentine, and inside that is the pulp. Think of the pulp as the neurovascular heart of the tooth. It's all the blood vessels and nerves.
And they enter at the very tip of the root.
At the apex, exactly. And crucially, the whole tooth is held in the jawbone by the periodontal ligament, the PDL. The PDL is like a shock absorber, and its health is absolutely critical for healing. If the PDL is damaged, that tooth is in deep trouble.
That connects directly to prognosis.
Yeah.
So if the PDL is key, what happens if the root itself breaks? We found this fascinating retrospective study.
I saw that one.
It shows that teeth with root fractures generally have a poor long-term prognosis, often ending in extraction. But it's not an immediate death sentence. The median survival time was 42 months.
42 months is significant. It means you can preserve the tooth for several years. But here's the critical distinction the research pointed out, and it's all about the direction of that crack.
Okay.
Teeth with a horizontal root fracture have a dramatically higher survival probability compared with teeth that have a vertical root fracture.
Why is that? Why is a vertical crack so much worse?
Well, think about it structurally. A horizontal fracture is still sort of held in place by the bone around it. The bone acts like a natural splint. But a vertical fracture runs right up and down. It turns the tooth into a wedge. So every time you bite down, you're driving that wedge deeper, disrupting any healing, and just letting bacteria get right into the break.
So it just becomes non-healing and infected almost every time.
Almost inevitably, yes, which leads to extraction.
That makes figuring out the crack's orientation the absolute #1 diagnostic step. Now, let's move into classifying the trauma. The IADT guidelines group them into 2 main types: fractures and luxations.
Luxations are basically displacements. Things like a concussion, a subluxation, or a full avulsion.
When you're diagnosing a luxation, you're looking for what? Pain, mobility, and sound.
That's the trifecta. A minor injury might be a concussion. So the tooth hurts when you tap it, but it's not visibly displaced or wobbly.
So for a concussion in the ER, the treatment is basically just observation and a non-urgent referral to a dentist.
Precisely. Then you have subluxation. Now, the tooth is definitely wobbly. You see bleeding from the gum line, but it hasn't actually moved from its spot.
And then we get to the really severe ones, the intrusive or lateral luxations.
Correct. For these, the tooth is either immobile, because it's jammed up into the socket, or it's pushed sideways. And this is where that sound check is so critical.
The metallic sound.
Yes. You tap the tooth and you hear this distinctive, high metallic tone, an ankylosing sound. That sound tells you the PDL has been crushed and the root is probably fusing to the bone.
Okay, now here's where it gets really interesting for me. Testing the health of the pulp right after an injury. We use these electric or thermal tests, but they only measure the nerve firing, not the actual blood supply.
Exactly. We call it pulp shock. For weeks, even months, after a trauma, the nerve might just stop responding. It gives you a false negative. The tooth might be perfectly alive, but the nerve isn't talking.
So testing right after a trauma can be completely unreliable.
Highly unreliable.
So if those tests are out, what's a better indicator of whether the pulp is viable?
Well, for mature teeth, it's often just time and observation. But the gold standard is measuring blood flow directly. Hemoperfusion, things like laser Doppler or flowmetry, but that's rarely available in an emergency setting.
I see.
However, if the tooth does test positive initially, if the nerve does fire, you can be pretty confident the pulp is okay.
And the prognosis is wildly different for a tooth that's not fully developed yet, isn't it? An immature tooth.
Oh, massively. The IADT classifies these as NOLA stage 9 or below. Essentially, the root tip isn't fully closed yet. It's still shaped like a funnel.
And experts actually break that down even further, right? The very young tooth versus the adolescent tooth.
Yes, and that distinction is crucial. The very young tooth, so NOLA stage 8 and below, has a huge advantage. That funnel opening at the root tip is so much larger.
So more blood can get in.
Exactly. It provides a much better chance for revascularization. We call it the open pluming effect. If you can get that blood supply back, you can save the tooth without a root canal.
So the patient's age is maybe the single biggest prognostic factor. Okay, let's jump into the emergency field. The ultimate dental emergency, avulsion, a tooth knocked completely out.
This is where speed is everything. We are on a critical timeline. You must aim to get that permanent tooth replanted within 60 minutes.
60 minutes.
Every minute that passes, more of those precious PDL cells on the root surface are dying. And the key instruction for anyone on the scene, handle it by the crown only. Never, ever touch the root.
Okay, so you're at a game, you're miles from a dentist. You need to store the tooth to keep those cells alive. We always hear about milk. Is that really the best option?
Milk is accessible, and it's definitely better than water or just letting it dry out. But no, it's not the gold standard.
Okay, what is?
This is a key takeaway. Research consistently shows that a specialized medium like Hank's Balanced Salt Solution, or HBSS, or even simple oral rehydration salts are way more effective than milk at keeping those cells alive.
So if you're a coach or a school nurse, having HBSS is ideal. But failing that, the salts you use for dehydration are a great backup.
A surprisingly great backup. And saline, which seems like it would be good, is actually less effective than milk. It's not physiologically balanced for those specific cells. The hierarchy really matters.
Let's talk about stabilizing a tooth in, say, an ER where there's no dentist. They have to provide interim care for a luxated tooth. What can they use?
The goal is a short-term, passive, flexible splint. You want stability, but not total rigidity. The tooth needs a tiny bit of movement to help the PDL heal.
Okay.
So you can use simple things like a thin stainless steel wire or a cement called glass ionomer cement, GIC.
Tell me about GIC. It sounds like a great tool for an on-the-fly splint.
It's excellent. It's a 2-part cement powder and liquid that hardens on its own in about 1 or 2 minutes. It sticks right to the tooth. You just use it to glue the injured tooth to the healthy ones on either side.
And what if it's a really bad fracture, an LS3, where the pulp itself is exposed?
That exposed pulp needs immediate protection from, well, everything. So first you apply a layer of calcium hydroxide paste, or KOH2.
What does that do?
Its critical job is to stimulate the tissue underneath to form new dentine. It's basically trying to get the tooth to heal itself.
It's like a biological Band-Aid.
A perfect analogy. Then, once that paste is on, you have to seal it. And that's where GIC comes in again. You cover the calcium hydroxide with GIC to make it impermeable.
The source mentioned getting creative, like using a paper clip.
Yes. For a bigger injury, you can fashion a little arch bar by trimming a paper clip, and you just embed that into the GIC while it's still soft. It's a temporary fix, but it's incredibly effective for getting a patient to definitive care safely.
That is a great piece of practical advice. Lastly, for emergencies, an avulsed tooth that's been put back in. What systemic care is needed?
Because those teeth are often contaminated and maybe they fell in dirt, systemic antibiotics are required. Amoxicillin or penicillin are the first choices.
Okay.
And a crucial step that often gets missed. You have to consider a tetanus booster, depending on their vaccination history.
Right. So moving on from the immediate crisis, let's talk about long-term prognosis. How does the pulp try to heal? There are 3 main paths, right?
Right. The ideal outcome is, of course, normal pulp healing. We see that after mild injuries. But then you get this interesting response in more severe cases called pulp canal obliteration, or PCO.
Pulp canal obliteration sounds bad, like the canal is closing off. Why is that actually a good sign?
It's counterintuitive, I know. But It's a favorable outcome because it means the tissue survived and is actively responding. It's laying down new dentin inside the canal, which makes it narrow. The tissue is alive, it's just protecting itself.
So the bad outcome is when it just dies.
Exactly. Called necrosis, that's when the tissue dies, you get an infection, and you're almost certainly looking at a root canal.
The other major long-term complication we have to discuss, especially for kids, is ankylosis.
Ankylosis. This is when the PDL is destroyed and gets replaced by bone. The root literally fuses directly to the jawbone. It's permanent.
So what does that mean for an adolescent who's still growing?
For a growing kid, it's a huge problem. The jaw and the other teeth keep growing and erupting, but the ankylosed tooth stays put. It gets submerged. It looks shorter and shorter over time, which affects function and aesthetics.
Whereas in an adult, it stays at the right height, but you still get that metallic sound on percussion.
Exactly.
And the treatment for a submerged tooth in a growing child sounds pretty radical.
It can be. Sometimes you can manage it with a crown to make it look longer. But often, the definitive treatment is something called decoronation.
Which is?
It's a procedure where the dentist removes the crown of the tooth, but intentionally leaves the root behind in the jawbone to resorb on its own.
Why on earth would you leave the root?
To preserve the bone. If you extract the whole tooth, the bone around it often collapses. By leaving the root to resorb naturally, you maintain the width and volume of the jawbone.
So it's all about setting up for the future.
It's entirely focused on creating the perfect site for a dental implant once the patient is done growing. It's an incredible example of long-term planning.
That's fascinating. Okay, last big area. What about orthodontics after trauma? If a patient needs braces, what are the waiting periods?
The waiting period is absolutely non-negotiable. For a mild trauma, like a concussion, you still wait 3 to 6 months.
Okay.
For a moderately traumatized tooth, or any tooth that's had a root canal, you must wait at least a year. And that's a year after x-rays confirm the root tip looks completely stable.
And for the most severe cases, the root fractures.
For severe trauma, you're looking at 2 years or even more. The rule is absolute. You finish all the endodontic treatment, and you wait for healing before you start putting orthodontic forces on that tooth.
We've covered managing the injury, so let's end where we really should start. Prevention. What is the absolute gold standard for protecting against these TDIs?
Well, primary prevention is really 2 things. Correcting a large overjet with orthodontics and using the right protective equipment. And for equipment, the gold standard is, without a doubt, the custom-made sports mouthguard, a CSM.
Custom-made? They cost more? You have to go to a dentist. Why are they so much better than the boil and bite ones you can get anywhere?
It really comes down to fit, protection, and compliance. A custom guard fits perfectly, so it offers vastly superior protection.
And because it fits better, kids are more likely to actually wear it.
Exactly. It doesn't shift around. It doesn't make it hard to breathe or talk. The second a guard gets uncomfortable, compliance just plummets.
Let's get technical about the construction. What material and thickness do you need to actually absorb an impact?
The material should be FDA approved, usually something called ethylene vinyl acetate copolymer, or EVA. But more importantly, it has to have a laminated, multi-layered design, meaning you need one soft, elastic layer to absorb the initial blow and a more rigid layer to distribute that force across the whole dental arch.
And is there a specific thickness requirement?
Yes, and this is a crucial detail for you to remember. The labial surface, the front part protecting those central incisors, must have a minimum thickness of 3 to 4 millimeters. That specific thickness is what makes the science work.
3 to 4 millimeters, got it. And finally, you have this gold standard protector. How do you maintain it?
CSMs live in a warm, moist place, so they get gross. They need to be maintained daily. Rinse them, clean them with a soft toothbrush and soap, or use dissolving tablets, and always store them in a perforated container so they can dry out.
And of course, wear them for the entire duration of the activity.
The entire time.
This has been a really comprehensive deep dive. We've covered everything from emergency field care to multi-year treatment plans. We looked at the difference between horizontal and vertical root survival, the absolute necessity of that 60-minute avulsion window, and the nitty-gritty details of what makes a mouthguard actually protective.
The long-term commitment needed after a severe dental injury is it's immense. And considering those mandatory waiting periods, 2 years or more before you can even think about orthodontics after a severe injury, it raises a really important question for you, the learner.
Okay.
How significantly might that extended delay impact the overall treatment plan and, the developmental milestones for an adolescent patient?
It's a huge consideration. It demands patience, really precise monitoring, and a long-term commitment from everyone involved. We hope this deep dive has equipped you with the critical knowledge you'll need the next time you face a dental emergency.